Hello everyone. In this video, I will be discussing on the topic idiopathic thrombocytopenic purpura. In this video, we will discuss with the types and the clinical features. Immune thrombocytopenic purpura or idiopathic thrombocytopenic purpura. It is the most common form of thrombocytopenia as well as common form of immune thrombocytopenia. In ITP, there is increased destruction of platelets. I repeat, increased destruction of platelets by immune mechanisms and mainly by autoimmune mechanism. Hence, also referred to as autoimmune thrombocytopenia. Hence, ITP is also known as primary immune thrombocytopenic purpura or autoimmune thrombocytopenic purpura. It is defined as an isolated thrombocytopenia with normal bone marrow in the absence of other causes of thrombocytopenia. And ITP has two distinct clinical symptoms manifesting as an acute condition in children and chronic conditions in adults. So, what are the types of ITP? There are two major subtypes of primary ITP, acute and chronic. Both are autoimmune disorders in which platelet destruction results from the formation of antiplatelet autoantibodies. So, first one is acute immune thrombocytopenic purpura. Acute ITP, it is a self-limited disease of children between 2 to 4 years and occurs with equal frequency in both the sexes, and it often presents 1 to 3 weeks after viral infection, usually measles, rubella and EBV infection. And the platelet destruction is caused by antiplatelet autoantibodies, and these are IgM type of antibodies that combine with the platelets and result in destruction of platelet in the spleen. So at the end of this video, I will be discussing on the pathogenesis of ITP. So in ITP, platelet count is decreased and sometimes even below 10,000 to 10,000 per cubic mm. Now let's discuss the clinical features. The onset of thrombocytopenia is abrupt or sudden with petechiae, that is red patches over the skin, but do not mix up with the purpura. Purpura and petechiae, they are different. Petechiae will be smaller and purpura will be quite big. So as you can see in the picture, this is petechiae, they are small red spots, and purpura, they are bigger in size. So the onset of thrombocytopenia is abrupt or sudden with petechiae over the skin, gum bleeding, epistaxis, that is nose bleeding, and mild fever, which usually resolves spontaneously within 6 months. So steroid therapy is indicated only if thrombocytopenia is severe. And approximately 20% of the children, usually those without a viral prodrome, have persistent low platelet counts beyond 6 months, similar to that of chronic ITP. Now let us discuss chronic ITP, chronic immune thrombocytopenic purpura. Chronic ITP is defined as persistent thrombocytopenia. I repeat, persistent thrombocytopenia that lasts more than 6 to 12 months. 6 to 12 months, and this is an indolent and more common form of primary ITP, and this is usually seen more in adults. We will continue with immune thrombocytopenic purpura or idiopathic thrombocytopenic purpura with the pathogenesis. As we've discussed earlier, that ITP is autoimmune autoimmune type of a disorder. So autoimmune disorders which is characterized by the formation of antiplatelet antibodies. So ITP is autoimmune disorders that is characterized by the formation of antiplatelet antibodies which is directed against membrane glycoproteins, most oftenly GP2B, 3A and GP1P9 of platelets. So these are the receptors in platelets that you will find, and the antiplatelet antibodies can be demonstrated in approximately 80% of patients and are of IgG type. And this mechanism of platelet destruction is similar to that is seen in autoimmune hemolytic anemias, where autoantibodies are developed and they destroy our normal cells. So similarly, even ITP is also destruction of normal platelets by the immune system. So the antiplatelet antibodies acts as opsonins and are recognized by the IgG-Fc receptors that is present on mononuclear phagocytes of reticuloendothelial system, mainly in the spleen, and are destroyed there. That results in thrombocytopenia. And spleen is not the only major site of destruction of platelets, but also a very important site of autoantibody synthesis. Therefore, splenectomy, that is a removal of spleen, shows a marked improvement in about 70 to 80% of patients suffering from ITP. Okay, although destruction of sensitized platelets is the major mechanism responsible for thrombocytopenia, the autoantibodies probably also affects production of platelets by the megakaryocytes and also impair the platelet function. So that's why after removing of the spleen, the patient shows a marked improvement. Okay, so now let's come to the diagram of pathogenesis. We can see that this is a platelet and we have the receptors GB2B, 3A and GB1B9. So these receptors, against these receptors, autoantibodies are formed. Antiplatelet antibodies are formed against these receptors, which attach to the receptors. As you can see in the diagram, this antibodies comes and attach to receptors, and with the FC receptors, with IgG FC receptors that is present here, that is present in the mononuclear site, they come and attach here. They come and go to the spleen. So mononuclear phagocytes recognize the antiplatelet antibodies here in the spleen, and destruction of platelets by macrophages happens here. So that is how platelets are being destroyed and thrombocytopenia occurs. So that is all about immune thrombocytopenic purpura. I hope you have understood with the pathogenesis. Laboratory findings: in peripheral blood, platelet count is markedly reduced and is below 80,000 per cubic mm. Hemoglobin, the level varies depending on the duration and the amount of bleeding, and ranges from 7 to 12 gram per TL. Remember, it depends upon the duration and amount of bleeding. Now coming to the peripheral smear, platelets, there is marked reduction in their number, that is thrombocytopenia, and accelerated compensatory thrombopoiesis that often leads to the formation of abnormally large-sized platelets, or we call it as mega thrombocytes or giant platelets, that is detected easily in a blood smear. The RBCs, coming to the RBCs, anemia develops in patients who have appreciable blood loss over a period of months to years. And chronic loss of blood may result in microcytic hypochromic anemia. especially in females with menorrhagia. And WBCs, they are usually within normal range. Now coming to bone marrow, the cellularity, the bone marrow examination is important to rule out thrombocytopenias resulting from bone marrow failure. A decrease in the number of megakaryocytes argues against the diagnosis of ITP usually. The cellularity bone marrow is hypercellular. Now coming to megakaryopoiesis, that is in the bone marrow, you will find that bone marrow shows moderate increase in number, or both increase in number of both immature as well as mature forms of megakaryocytes. Immature megakaryocytes are predominate, and they have large non-lobulated single nuclei and basophilic cytoplasm. Coming to erythropoiesis, bleeding from thrombocytopenia, as I've discussed, may result in anemia, accompanied by normoplastic erythroid hyperplasia. Without constant bleeding, iron deficiency anemia may result in normoplastic erythroid hyperplasia. Myelopoiesis is usually normal. And iron storage. In patients with severe and chronic bleeding, iron deficiency develops, resulting in depletion of iron stores. Now coming with the bleeding time, with the other tests, their bleeding time prolonged, but prothrombin time and activated partial thromboplastin time are normal. Tourniquet test positive, clotting time normal, and test for platelet autoantibodies may be positive, usually positive, and spleen may be normal size. So spleen, the size of the spleen is normal on histological examination, and spleen shows non-specific changes like congestion of the sinusoids and prominent germinal centers. In many scattered megakaryocytes are found within the sinuses and sinusoidal wall, which may represent a mild form of extramedullary hematopoiesis due to elevated levels of thrombopoietin. So this is all about lab diagnosis. So now coming to the summary of ITP. So we've discussed that ITP is the most common form of thrombocytopenia, as well as common form of immune thrombocytopenia, and there is increased destruction of platelets by immune mechanisms and mainly by autoimmune mechanism. Hence it is also referred to as autoimmune thrombocytopenia. Now acute, we have two, acute and chronic. So in acute, ITP is mainly seen in children between 2 to 4 years, and acute ITP is autoimmune disease, sudden onset, shorter duration, and usually resolves within 6 months. But in chronic, autoimmune disease and the antibodies are directed against glycoprotein 2B, 3A of platelets. And spleen is a major site of destruction of platelets and important site of autoantibody synthesis. In ITP, platelets are reduced, that is thrombocytopenia, and platelets reduced below 80,000 per cubic mm. And the bone marrow in chronic ITP shows megakaryocytic hyperplasia with immature megakaryocytes, and peripheral smears will show abnormally large size platelets called as the giant platelets or megathrombocytes. And next is the ITP, that is bleeding time is prolonged, but prothrombin time and activated partial thromboplastin time will be normal. That's all about the lab diagnosis and all about ITP. I hope you've understood. Thank you.